In this video, we are going to discuss how to calculate the velocity time integral when you are looking at the heart. Now, the VTI is a component that you need to calculate the overall cardiac output in a patient. Most of the time, however, the point of care provider is not really trying to figure out exactly what the cardiac output is. Rather, they're trying to just figure out what the VTI is. And this is in the setting of trying to see if your patient is volume responsive or not. And what that means is if you were to give your patients fluids, would their cardiac output increase? And we really can do that just based off of the VTI in of itself. Now let's talk a little bit about what the VTI is. What the VTI represents is the length of a column of blood as it passes through the aortic valve in one heartbeat. Your probe of choice for this calculation is going to be the phased array transducer. And you are going to use that transducer to get an apical 5-chamber view of the heart. Now, it's very similar to an apical 4-chamber view, except for the fact that instead of just 4 chambers, you're going to get 5. And the 5th chamber is the LVOT, or the left ventricular outflow tract, and the aorta. Once you get that view, you're going to place your pulsed wave Doppler over that area, and you want the gate, those 2 little horizontal bars, to be just proximal to that aortic valve. The pulsed wave Doppler is that Doppler that makes that real cool sound. Here is an example of performing a VTI calculation. Now, this is not the best apical 5-chamber view, but we're able to get a good view of the LVOT. I'm hitting the pulse wave Doppler again and getting this nice waveform. And for this example, I'm going to use one of the auto calculators. So what I'm doing is I am clicking a point at the beginning of the peak and then one at the end of the peak, and it's calculating that VTI for me, and it pops out at a VTI of 18.26. And for reference, a normal VTI ranges between 18 and 22 centimeters. Now, one thing I have to say about the flow of blood and the angle of your pulse wave Doppler gate is you want to make sure that you are as close to 0 degrees or 180 degrees. You want to be perfectly aligned. There's a little bit of an angle here, and that's okay. Some machines actually have a adjustment that you can make to show exactly which direction the blood's going to get the most accurate calculation. Here is an example of performing a VTI calculation on a patient with a very obviously depressed ejection fraction. So here I'm getting my apical 5-chamber view, and I'm going to now place the pulse wave Doppler gate right proximal to the aortic valve in the LVOT. Now this one, I'm going to be using a calculator to show the angle of blood flow to help the computer know where the blood flow is going to get the best calculation. And you can see already that this peak is significantly smaller than the other peak. I am going to do a couple of adjustments. I'm changing my baseline here. I'm going to increase my gain just a tad bit, and then I'm going to go ahead and manually trace this out. Now, this can be a little bit on the tricky side, but sometimes it's going to be more advantageous to manually trace it. And you can see here that the VTI here is 7.5, which is significantly less than the normal 18 to 22 centimeters. For the most part, when we are performing a VTI is to see if the patient is volume responsive. So what we'll do is get a baseline VTI, do something, so either a passive leg raise or give a fluid bolus, and then recheck the VTI. If the VTI between the interventions increases by 15 to 20%, your patient is volume responsive and you can give them more fluids. And just to clarify, the passive leg raise, you should start with your patient with their torso actually up at about 45 degrees, do your VTI, lay them down flat, and then lift up their legs to 45 degrees and then recheck it at that point. To recap, your view to get the VTI is going to be the apical 5-chamber view. The tool you're going to use is the pulsed wave Doppler setting, and then make sure to do repeat measurements before you do either your fluid challenge or your passive leg raise, and then after you do that. If you have an increase of 15 to 20% in that cardiac output, your patient should be considered volume responsive. That's it for this 5-minute Sono video. If you have any questions or comments, please feel free to reach out via email or social media.